Okay, it is 12:02. I think we'll go ahead and get started. So welcome everyone. My name is Sarah Meanirod and I am the PDRN coordinator with DO-Touch.NET. Thank you all for joining us for this month's episode of Let's Talk About OMM Research. Before we begin, let us take a moment for the housekeeping rules of the webinar. Please add your name and location into the chat for accreditation requirements. If you have registered for CME credit, you must add your name into the chat to verify your attendance in order to receive CME credit. Additionally, you will need to complete the physician attestation form, which was emailed to you this morning, and the evaluation survey, which will be emailed to you this afternoon. The Let's Talk About OMM Research Planning Committee has no conflicts of interest to disclose. If you have any technical issues during the webinar, please send a message to me, Jane Johnson, or G. Franklin, and we will help you. If you have any questions or comments during the presentation, please feel free to type them into the chat, and please feel free to address each other's questions and comments there as well. After each presentation, we will have time for discussion and questions. If you would like to speak during the discussion, please raise your hand and we will unmute your microphone. We ask that you briefly introduce yourself and please feel free to turn on your camera if you would like. When contributing to the discussion, please limit microphone time to 3 minutes to allow for everyone who wants to participate in the discussion. Please keep in mind that this webinar is being recorded and will be placed on the DO-Touch.NET website, where you will have the opportunity to continue the discussion. Watch for an email from DO-Touch.NET announcing when the recording and discussion are available. Now, please help us welcome Dr. Jenny Zamor, who will be speaking about OMT and lower back pain in obese and pregnant patients. Dr. Zamor graduated from Ohio University College of Osteopathic Medicine, completed an OB-GYN residency at Obese Memorial Hospital and an NMM fellowship residency at Cleveland Clinic Foundation, both in Ohio. She has vast experience in private and hospital practice and is currently an assistant clinical professor at Ohio University Heritage College of Osteopathic Medicine. Dr. Zamor currently serves as the Vice President of the Columbus National Medical Association. There are no conflicts of interest to disclose. Please help us welcome Dr. Zamor. All right, Dr. Zamor, I am going to switch to your PowerPoint and then we can get started.
Okay. Well, I'm going to start talking. Is that good?
Yes, please do. Go
All
ahead.
right. So good afternoon, everyone. Thank you for the wonderful introduction. I'm really excited to present these two articles. I did a whole bunch of searching just to find something that was interesting. So bear with me. I hope you found it interesting as well. Next slide, please. So I have no conflicts of interest, just like the DO-NET group. Next slide. Today's objectives will be to first present the articles to you, to include the methods and outcomes, and then point out some impact that could help us with clinical practice. And then hopefully it brings up discussion points for us today. So as you know, the Journal Club articles that I picked, basically OMT in obese patients with chronic back pain, and then OMT in women with postpartum low back pain and disability. So I found this very interesting. The reason why I picked them is because I wanted to learn more about how to set up pilot studies, how to set up sham, how to set up a randomized control trial. I think that's the nirvana of research, to be able to do one that way. So I wanted to learn that. Also, low back pain, honestly, is such a problem in our healthcare, and it's been proven by other journals other articles that OMT is underutilized and OMT still needs to have some more research done. Some of the research articles just quickly pointing, like the Dirty Half Dozen with Dr. Greenman in 1996. And then the other article that you see right here that basically was also looking at chronic back pain, but what it did not find was, even though it was a good study, it didn't actually say and point out that OMT was the reason why the patients felt better. So the first article that I'm going to be talking about, actually, I think they do a pretty good job of trying to prove that. The other thing is obesity is associated with a lot of musculoskeletal complaints. Average American is probably overweight. And I think in medical education, this is where I get on a little soapbox about how we train our students to progress and continue to use OMT at the basics level. I think we have some model standardized patients, but as they get better with their skills, I think they should be challenged with some other challenging patients like someone with obesity. The other thing is low back pain in pregnant women and postpartum women is very common. It can lead to long-term disabilities and long-term disabilities and problems, and even problems for the next pregnancy. So when you're comparing, I mean, this is the ideal world. Can everybody see my I don't know if you can you see my pointer? You probably cannot. If you see the first picture is just kind of looking at the anatomy trains and the perfect shape, and how all the lines cross on the body. We learned that in class, but when you start to get more girth, especially anteriorly, you're going to have a shift of your of the center of gravity, which is going to cause a tilt to the pelvis, especially anteriorly. And in response to that, the back's going to extend a little bit more, and that's where back pain starts. And so ensues, I mean. And basically this other photo is just, I like this picture of the fascia because you can get a lot done with fascial approach and ligamentous approach, especially with back pain. So mechanics of pain, if you slimify it, you're going to think about your core muscles like your psoas and having trigger points and referring pain. And that can be a reason why someone can have back pain. Or what about the piriformis? That's another reason. But the one that you really want to make sure you rule out are radiculopathy. You want to make sure that you look at your red flags and rule those things out first. But decreased thoracic spine range of motion also you have abdominal, fascial drag and sag, and that's what that middle picture is showing, and the increased lordosis. So I think that explains the patient with obesity and the patient that's pregnant and becoming more pregnant.
Dr. Zamor, I just want to make sure I'm keeping up with you. Am I showing the correct slide?
Oh my goodness, I've been flying through. Do you have the slide that has the 3 photos of it's slide number 6 is what we're on.
Yes. Okay. That's the one I'm on. Okay. Just
So
want to make sure I was keeping up with you.
Yes. Sorry,
okay.
Miss Sarah. Please go ahead and go to the next slide.
Okay.
Please bear with me. I'm sorry. It's a little nervousness, but that's a good thing. I heard that when you're nervous a little bit, it means you really, really care. So I really, really care a lot today, guys. So this is some structural changes that happen in pregnancy and just pointing out some of the, basically we were just saying about the postural muscles, but then you have some muscles that also decide they want to be tight from the back, and it changes. It almost looks like the woman has a shelf. If we're doing like, well, I think about when I'm talking to my students about this, when they have, when they're trying to evaluate a patient with zinc for screening, that I tell them you can have the patient standing up and you can look at the different diaphragms from head to toe, and you can see some of the changes just like that. But there are some muscles that actually get weaker, and abdominal ones are really the ones that get weaker. So that's why we talk about the sag. And the other thing that happens besides center of gravity, besides your pelvic tilt, besides your abdominal drag, and then your back being more lordotic, is that you're going to have a little overpronation happening. So it floored me when in my practice, because I was trying to make sense of, okay, their feet get big, but why? Is it edema? And then I realized, oh yeah, it's overpronation of their feet, and that's a big deal. That's a big deal. And so here, just kind of summing up the postural changes. And I just kind of mentioned everything already, but just reiterating that, and got the body's compensation. And the other thing is how they stand and locking their knees versus not. So you get muscle fatigue, you get muscle strain, muscle fatigue, and then pain. The big thing is both of these subgroups of low back pain have decrease in fitness. That means strength, mobility, endurance, balance. The other thing is there's a lot of deconditioning. So muscle fatigue eventually will lead to muscle imbalance. And then you have the decreased range of motion and the risk of having low back pain. All right, and OMM to the rescue. So you definitely can make a difference with range of motion, therefore mobility, and also restore balance and also lymphatic drainage and nutrients to the areas. So what the goals would be to really try to maximize your normal diaphragmatic motions, to open up your myofascial pathways, improve pressure, and mobilize your tissue and lymph. So let's get into the article. So this first article, OMT in obese patients with chronic back pain, was done in 2012. It's a randomized controlled study. It was done in Italy. The hypothesis was, is OMT an adjunct to exercise? Will it improve low back pain or more than exercise alone? So this particular group, I've been following them. They have done about four studies before this one, and I don't know if they're going to do more. So their previous one, they actually just figured out what exercises to use. They call them specific exercises, where they were trying to decrease neck pain and decrease back pain. So now they took 21 obese females with back pain. They put them in two different groups. One of the groups was the control group, and they were just getting the exercises that, like I said previously, they figured out that's what they wanted to use. And then the study group, they give them OMT. So the research question, is OMT plus specific exercises more effective than specific exercises alone? So if you tell your patient with obesity, go do these exercises, can OMT make a difference? So what we did for inclusion, basically you had to be over 18, your BMI had to be greater than 30, you had to have low back pain for at least 6 months, and you weren't supposed to have any medical treatment. And that's in both groups. Exclusion would be if they had back pain for a different reason: osteoporosis, osteoarthritis, neurological, cardiac, respiratory, or psychiatric disorders. The group, the specific exercise and OMT group, there were 10 women there. The ages were 42, plus or minus 12 years. The BMI was a range about 42 to 40 to 46. And then the specific exercise group, the mean age was 44, and it was 11 participants, and the BMI was about at 45. So basically, these are the parameters that they were using to kind of even out the playing field of both of the groups. So these were the methods, and they randomized them with a computer. So they were given envelopes. They didn't know which group they were going to be in until they did. And then there was an osteopath that confirmed the OMT that was needed. And they gave them pre and post evaluations for clinical scales, 3D motion analysis, trunk kinetics. They lost 2 of the participants because they weren't able to get the post evaluations information. So the methods, pretty much they had 10 meetings, and they did a good job with their introductory meetings. They wanted to teach them about obesity, how obesity actually affects the spine, and how it's a risk factor for them to develop back pain, to kind of get their buy-in. And then they actually had 4 different levels of exercise for all the patients did that. All the patients did that exercise, did those exercises that they picked out. And then they also gave them some information about ergonomics for activities of daily living. That was to improve their, if they were doing specific exercises and we're trying to improve their balance, mobility, and fitness, we want them to continue that at home pretty much. And then specifically for the OMT group, what they received HVLA, cranial, myofascial release from osteopaths who had at least 3 years or more postgraduate experience. and they were treated on the individual basis according to the somatic dysfunction definition that we all know. So these were the level of exercises. Pretty much it was core and breathing and using their posture, motor control, the pelvis and the spine. And with the pelvis and the spine, they were moving about in all different positions for that. And then the last one was the truncal extension. So just trying to increase their capacity to, if they were having a decreased mobility of their thoracic spine, that means that when they're bending down, they can't reach their toes. Pretty much that's what they're doing. They're checking to see if how far down can you go and how is your thoracic your thoracic spine stiff. Because one of the studies that this group had done in the past was that they did put some electrodes on the different regions and found that the thoracic spine was the area that was the earliest to have stiffness and the most out of all the others. So what I thought was really, really exciting when I looked at the outcomes was that Vicon 460. I thought it was so interesting that they used, I think it made it more scientific-y, because they had all the electrodes that they put on, and then they could measure things. So they had a standard that they can use to evaluate, and they did that with everyone. So the other parameters they used was using low back pain clinical scales, which some of you are already familiar with. They used 3 of them. And then for their statistics and findings and trying to gather their data, they used different these marker tests. And they said that they weren't even, and they had to use other ones to like calibrate and fix it. So they were trying to fix errors. The error, like just to make it more specific. So yeah, so this is kind of the photo that you probably already saw and read. I just thought it was so awesome that there was a way, you know, I always thought, how can I know how much someone's moving? So there are machines. This is a 6-camera motion machine that actually can check your truncal flexion. So it was kind of neat to learn about that. They started off with their exercises without exercise at all, and just saw what they could do passively at first, and then they just did with different levels, and they tested it each time. So results for this study, I thought they were good. There was good compliance. Like I said, they had lost 2 patients because they couldn't get post information. Both of the groups improved their clinical scales, but the OMT group had more than the specific exercise alone. There was like a 20% improvement in thoracic spine biomechanics in that group. So that's pretty neat. And specifically the range of motion was better and improved. For their data analysis, they used a program called SMART. I didn't want to get into that too much. And there was, let's see. Oh yeah, they use SMART, and that's that photo that I just passed. Oh, did I tell you to move on to the next slide? Probably not.
No, ma'am, you didn't, but I'm trying to read your mind and keep up with you.
Okay, results we should be on slide 19.
Yes, ma'am, you are.
Are you good? Okay,
Yep.
Thank you. I'm so, you got to catch me on that. I'm just going.
It's okay. I'm trying to keep up.
Okay, thank you.
You're welcome.
So basically, like I said, each person started off with parameters that were calculated. They looked at the differences. They did pre and post group activities, and I think they were really diligent about that. So this was a table that just pretty much was showing the mean values and the standard deviations for forward flexion angles. What do I have to point out for you? So at the pre, let's see. So at pre, I don't know if you could see me, you can see this. Well, basically they listed the pre, they listed the post, and then they had like the p-value was supposed to be greater than 0.5 was their like standard that they were trying to use. But you could see that there was a 20% improvement in alpha 3. Alpha 3 was the one for thoracic. So that was the one to pay attention to there, with the range of motion being improved. So next slide. Did I go a little too far? Yes. Next slide, please. Thank you. So the next, so that was done with that article. The next article is the postpartum article. So that's also a random controlled trial. It was actually published in JAOA, so that's why I got this one. I'm like, oh, I got to present one of these. So it was in Germany. It was done by 2 private practices and by 2 osteopaths, and it came from the German Academy of Osteopathy, which I would love to visit one day. The hypothesis was OMT is effective in reducing postpartum. Is OMT effective in reducing postpartum low back pain, pelvic girdle pain, and functional disability? They had 80 patients in this one. They were in reproductive age, and they used computer to basically put them in 2 different groups also. So the control group, they had no OMT. And this was an 8-week, I said an 8-week study. It was an 8-week study. So no OMT for the control group and then OMT for the control group. I mean, for the standard group, the study group. The control group were promised, they were put on a waiting list, and they were given 2 free treatments after the study was over. So, and they were not allowed to use any medicine or anything. One of the neat things, I'm going to pause for a second. Like I just said that there were 2 osteopaths. It was neat because they talked about what defined the osteopath, and they called it heel practica. That means that they're allowed to see patients without supervision, and these are people who have had 5 years of osteopathic training, which is 1,300 hours, and that they passed this huge final exam. So they're the heel practica. If someone can help me with that, that'd be great. Like I said, the research question: how effective is the OMT in reducing postpartum low back pain and pelvic girdle pain and functional disability in women with low back pain? So the inclusion criteria, they're between 18 and 42. They recruited them between 2010 and 12. And like I said, it was in Germany, and they had to be at least 3 to 15 months postpartum. And their low back pain or their pelvic girdle pain was supposed to be for at least 3 months. Their intensity of their back pain had to be 5 or higher. The results from last postpartum GYN visit had to be given because they want to prove that, yes, this person has been having back pain for this amount of time. No medical treatment was allowed. No other manual therapy was allowed. Exclusion criteria: if you had back pain from before, you couldn't be in it. If you used any medicine at all for your back pain, you couldn't be in it. If you got pregnant, you couldn't be in it. If you had osteoporosis, osteoarthritis, neurological problems, and chronic inflammatory disorder, or if you had primary neoplasm with some mets, because that can present as back pain. The prevalence of, the risk, low back pain episodes are risks for developing lumbopelvic pain after pregnancy. That prevalence is 24% without and versus 43% with previous back pain. So methods. So the control group, no OMT. Next slide, please. No OMT, but they were put on the wait list, like I said. 40 women filled out their VAS, there's a visual scale, and then the Oswaltry scale as well. They did that for the initial day, and then after 8 weeks. The study group, they got OMT, they got a baseline, and they had OMT 4 times, so 2 weeks apart, and they lasted between 40 minutes and 60 minutes, and only 2 osteopaths actually treated, and they used indirect or direct. It was up to the clinician to decide, and so there was no real standardized protocol. So, and they still also used the other clinical scales that I mentioned, but they used the standardized form for both of the osteopaths to fill out and document so they can talk to each other about it. Let's see. Yeah, that's all I have to say about that. Next slide, please. So this table is pretty much showing the demographic differences, and I'm sorry if you can't see it well, but I know you have the article. So basically just showing how successful the randomization was. That's just what that's showing. They looked at age, and they looked at number of deliveries and how long labor lasted, and trying to see if there was some sort of correlation at the end or something they found out at the end, and it really wasn't much. They also looked at postpartum complaints, and the complaints that they looked at were urinary incontinence, headache, dyspareunia, hemorrhoids, and anal incontinence. So they were just trying to see, were these related to did these get better? Are these related to their pregnancy or not? And maybe if someone had, they might find some secret correlation with the OMT group versus the non-OMT group, is what they were using that for. So pretty much, I mean, the visual analog scale is mainly for pain, and then the Austria scale is for well, it's pain too, but it's more for disability. And then it reports itself in percentages. It includes your pain intensity, activities of daily living, sleep and motion, self and sex life, social life, and travel. So next slide, please. So additional clinical questions that they gave, like I said, was related to childbirth, which I just mentioned. They used, I think they used a PASW, P-A-S-W. I think that's the name of their computer program that they use for their analysis. The conclusion was the study shows that postpartum low back pain, pelvic girdle pain, and disability were improved when treated with OMT. Next slide, please. And let's see. I'm trying to look at this closer. Okay, so this one is still just showing the differences between your two clinical scales, pretty much. And what the highest pain was up to 10. You remember they had to have a pain of 5 or more. And this is just looking at the changes between the groups, pointing out that pointing out that pretty much what the control group started at and what the OMT group started, they're just trying to show that the baseline was similar, but then look at the conclusion, look at the score of the visual one, it's at 2, while the control group is still at 6.5. So basically these women for 8 weeks were just like kind of suffering. They can't do anything, but their pain went away a little bit, got a little bit better with some time to 6.5 pretty much. And similar for the other Oswaldi index, but that was like, we're looking at the percentages of them being able to function. So the difference at the end was 20% versus 4%, like disability index. So the group that had the OMT was much lower. Next slide, please. That should be slide 30. So then this is a figure that's just showing the OMT. It's just basically showing what I just said, and how much it dropped for the OMT group versus the control. Just a different way to see it. I like this way better, just easier to see the difference. So the results, so 137 was screened, 57 were excluded, 2 dropped out because 1 got pregnant and 1 took meds. 1 couldn't take it, I guess. And then baseline clinical and demographics, they tried their best to try to make the difference to be very low. Decreased their pain, the pain intensity. Decreased pain intensity in the group. Like I said, the OMT group was lower after 8 weeks. So there was a 73% improvement, while the control group had a 7% improvement, even this, and this is after 2 treatments. So they waited for the control group to get their free treatments, and then they evaluated them again with the clinical scales, and only found them to get better, like just by 7%. So when I was thinking about that, I was like, you know what? I guess they lingered with the pain for so long. Did it get more chronic? And so it was just harder to treat? Did it get from they started at a 5 or a 6, it went up to a 9, and it was just hard to come down to a lower level. So I just was trying to ponder that. Maybe that's something we can talk about. One thing though, the study here could not establish pregnancy-related data, the data that I was saying that there are other questions they had clinically. And so discussing both of them, I tried to put them by side with each other. So in the OMT obesity one, there was 20% increase in your thoracic range of motion. In the sagittal plane, like you're reading, even though the specific exercise group, it just helped pain only. So it did not make a change for the range of motion. Only the OMT group did. Yay us. But then when you look at your OMT in a postpartum patient, there was a 73% improvement in everything, in ability. Remember, we use a disability, Oswald-Tree disability scale. And so it improved back pain in all those things. So both groups were good at trying to homogenize their groups. The group for the obesity group, I thought it was a good example of a randomized control study. I think the sample size was small, that made it weak. I wasn't sure about the number of osteopaths. They said that there were osteopaths and they had to have 3 years of experience post graduation, but I still didn't know if it was one osteopath or what. So I thought that could have been tightened up just a little bit. So I liked the fact that they gave us the criteria, the credentials, and why the 2 osteopaths in the other group that they had them, that they showed that they were capable and competent to perform the study with them. Okay, and let's see. Okay, yeah. So the follow-up for the obesity group, the follow-up for the study to their previous one, I already said that to you guys. I said that they did a great job with their setup. I love the use of the Vicon 460 and the markers. It made it more like a scientist. But I couldn't tell, but they still said they couldn't tell if thoracic stiffness was due to the muscle activation or ligamentous retraction. So I think there's going to be another part of a study that they'll do with that. The postpartum group, when you look at their wait list, with their wait list folks, like they knew, it was unblinded. They knew that when they got their envelope and they're not going to get OMT, they knew it. And only the study group could have real follow-up because the control group never got OMT until the study was over. If they got OMT, the 2 free OMT treatments they were promised during the 8 weeks, maybe there could be a different type of follow-up for them, but they had to get it afterwards. So it wasn't a good comparison. Like I said, the control group actually didn't have much improvement after the 2 treatments after waiting a full 8 weeks. So I suspect worsening from no treatment, higher pain, and that's my opinion. Hopefully someone agrees or someone gives me a different perspective when we talk. So I had to throw in something with AT Still, one of my favorite. I still can't believe that he would walk around and have these flyers and solicit business by this, but I love that. Find it, fix it, and leave it alone. You know, we say it and we preach it and we look at this flyer, but sometimes it's hard to actually do that and leave it alone, especially at the student level, really hard. So that was that. So osteopathy is finding health, not disease. And so in both of the subgroups that we have postpartum, we have obesity, we have 2 conditions where there's deconditioning, the decrease of fitness, but we still have to try to find health in that. So that concludes my talk. I'm so thankful for the opportunity to speak to you. That's the last slide, I believe. And here's my information, the last slide, for any further correspondence. Thank you.
Thank you so much, Dr. Zamor. I was trying to keep up with you, so I didn't look at the chat, but I'm going to do that really fast. If anybody has a question that they would like to ask, you can raise your hand and we'll unmute you.
Will I be able to see that?
Should be able to. Let me stop sharing my screen, and then you should be able to see everybody.
Okay.
And it looks like Dr. Downs has a question.
Okay.
Mm-hmm. Well, I think it's mostly I have comments. You know, one of the things that with the obesity study, I had a couple of concerns. One was the Vicon equipment. You know, there was probably something in the bibliography that told how it was standardized and stuff, but I had no idea as to how reproducible that particular test was, what the degree of variability would be. And so, I had some concerns with the stability. The other thing that wasn't described in the study was when the OMT session was done. Was it done before the exercise program? Was it done midway through? Was it done towards the end? And so, because it makes a difference, if the exercise program might have been helping maintain flexibility if it had been done at the beginning, or it may have, been something which happened, only at the tail end of things. So I had some issues with that not being disclosed. And then with regards to the chronic pelvic pain and postpartum pain, I love to disagree with Brian on this all the time. My opinion is that that's the perfect study. You let the DO go in and do what needs to be done instead of trying to limit things to a protocol, because I always feel that there's so much variability between patients and what's really causing their symptom complex that protocol stuff is hard to work, is hard for me to wrap my head around and so forth. So I'm waiting for Brian's defense, but I love the fact that it was, just let them go at it and see what kind of improvement you can get.
Thank you so much, Dr. Downs. Dr. Zamor, did you have any response?
Yeah, when I was thinking, I thought, because I look at the promote study and it had a protocol and it seemed rigid and structured. When I was looking at both of them, I thought that having a specific protocol of what they actually were allowed to use would have been more a way to standardize their like how well was, and they didn't do this, but whoever got myofascial release versus whoever got a cranial, and how did that play with their answering of their disability or their pains clinical scale. So I kind of wanted to know that, but that's kind of hard to do, I guess, unless you just do one technique at a time. It'd be nice to know which ones kind of work, but I could see your point about letting them go and just let the clinician be the person to decide what they see and treat it, fix it, and leave it alone, like we just had in the flyer.
Dr. Ellis, did you want to make a comment or ask a question?
It would be more of a comment.
Okay.
Thank you very much for these two resumes. I know those, not every one of them, but I know some of those Italian osteopaths. They're very, very good osteopaths. They have a wonderful study group. They do great articles. I'm asking myself, they had two groups, a control group and a study group. And what are we actually studying? What do we want to know from these groups? Does OMT help? Is what I wrote down, Dr. Moore. But is the study really about OMT or is it about exercise? If they want to know if OMT works, why was there not a third group with only OMT?
That's awesome. I thought that too. Yeah, or else even with a sham, like one that didn't really get anything, but they think they're getting something too, to see how that would compare. So yeah, that is a good point.
And if I may, I don't want to monopolize anything, but if I may, there was also the question I was asking myself. You said that they were giving ergonomic exercises to do at home. How do we evaluate the influence of these exercises? Is this not a BA in the experimental method? As I say, I know this group and I know they're very, very into exercise. For them, an osteopath is almost like a coach, and they are always suggesting exercise, but is this the best way to analyze OMT? I'm not sure. I'm just asking the question.
It doesn't have to be me to answer, but I think that they had already proven that, if we're talking about the obesity group, that they had proven the fact that their specific exercises helped them, whatever the specific ones were. And then they wanted to know if they would get more improvement with OMT. So it's more like we're testing OMT as being an adjunct to what they're already doing. That's what I thought it was.
Dr. Dean, did you want to ask a question?
Thanks. Yes. I think this a couple questions. One was kind of an add-on to what Dr. Downs was saying. I get called up to OB triage in the hospital for acute musculoskeletal pain, and they rarely have the same dysfunction from patient to patient. And maybe it's different for chronic low back pain of pregnancy, but sometimes the ribs are locked up or the diaphragm. Sometimes it's like a round ligament that's hanging up and causing back pain. But it would be interesting. I don't know. I just wondered if Dr. Zamor, that was my question, knew of any acute musculoskeletal pain of pregnancy studies that exist. Because I find that a protocol would probably not give me the same outcomes in the hospital.
No, I wish I can personally have a study. I have an idea about one of them. One of the studies I would love to see. So I'm not really answering your question, but I'm going to say what I think, because so many times we have patients that present with, I think I'm in labor, and you rule everything out. And then I come in after I get all the everything's fine report from the nurses or the residents. And then I come in and do an osteopathic exam right in triage, which the students love.
Exactly.
I'll find pubes. It's a lot of pube stuff. And I think just because the pubes are tender, it's because the baby's head is right there, but it's actually pubes that are asymmetric. And if you have someone who has, we know most commonly you have anterior-rotated anominants, right? Because I just talked about that mechanics. But if you have the slightest with pubes, guess what? You have an upslip. You have an upslip that needs fixed. So I think a lot of that, and then sacral dysfunction, people are afraid to roll her over on her side and evaluate her. I like to, of course, I can't lay her on her prone. So seated position, and that's another another thing I really love. I'm so excited to be at OU at my alma mater to get to teach, because the things I do in my office or my intrapartum, that I said, well, this is me incorporating and applying what I learned. In a seated position, you can get your sacral information, but you could get your sacral information and find out. Totally. So there needs to be some more studies, acute studies that way. I would love to do that, a triage of just how many patients that are presenting with pubic dysfunction, around ligament dysfunction, and then they're thinking they're in labor. How many? How often does that happen?
That would be an awesome study. Thank you.
Dr. Zamor, we have a question in the chat. It says, are the exercise protocols from the obesity study available for review?
Yes, because you can look up those names. And I'm sorry, I don't think I put that in my references. I didn't reference that because I know that they referenced it in the article. So in their reference, they have referenced all their studies in that. So you can find it and read it.
Thank you. Does anybody else have any questions or comments they'd like to make? If you want to put it in the chat, we can ask it too for you.
So I gave a different, if no one, well, I'm going to wait to see if anybody has a question, but I also gave you guys a bonus article because of interest about obesity bias curriculum. And it was just amazing to see that Turo had actually done one and tried to evaluate it. But anyway, I think Dr. Dean has a question.
Oh, no, I don't think so. Dr. Degenhart, did you want to contribute, say anything, make a comment? There's lots of thank yous, Dr. Zamor,
Oh,
and
that's
lots of comments
awesome.
about
I
how well you
appreciate that.
did.
Thank you so much. So I would
Okay.
love to see, like I said, in our education, that we actually try to gear to patients that are a little bit more difficult to do osteopathic structural exam, and to challenge the students to figure out how they would use their mechanics and the patient's mechanics to try to still treat the patients.
All right. I don't think we have any more questions. Thank you so much, Dr. Zamor. I really appreciate you coming on and doing this journal club with us today.
Thank you.
Next month, October 21st is our next meeting, and it will be a network update. Oh, yes, Jane, I see you. Oh, Dr.
Deb
Downs.
has it. Yep.
Yeah, he's always mouthing off. I think that, yeah, it's important that your students have a chance to develop the hand skills necessary before they start tackling a lot of obese patients, because you have a long way to sink through some of that tissue to be able to get to where you need to be able to do an adequate assessment. And so it would not be appropriate for first or second year students.
No.
Yeah.
Yeah, I was talking that they've done their first and second year. They have a proficiency where they can move on to their third and fourth. The general population does have a higher BMI, and that the reason why I'm saying that, because that becomes a challenge for the student. I see that. So I'm just proposing that maybe that could be something that we can gear towards teaching at least somewhere.
And I think there probably needs to be more, that there would need to be an awareness on the part of the instructor that that person is going to need better corroboration of their assessment. That you don't just send them in there, have them make an assessment and assume that they're right, that there needs to be some, a co-evaluation to be able to, support the evaluation, or to bring the student to a place where there is some concordance.
I agree.
Oh, that's it. Okay.
Thank you, Dr. Downs. All right. So like I was saying, our next presentation, our next meeting is October 21st at noon Central US time. And it will be our network update. So Dr. Degenhart and Jane Johnson, our directors, will be talking about what's going on with the network. And we'll give some more information about the annual meeting and what to expect in March, and everything else that's going on. So I hope you guys join us then. Save the date. And in the meantime, join us on social media. And thank you for joining us today. Thank you so much, Dr. Zamor.
You're welcome. It was a pleasure.